Welcome to Optimity Advisors Integrated Healthcare Webinar Series. My name is Obinna Onwude, and I will be presenting the third webinar of the series. In the first webinar, we took you along on a discourse of the challenges faced by health systems and how these are being addressed through the integration of care with patients at their center. The different meanings people adduce to integrated care, and the main elements typical of accepted definitions of integrated care found in our study for Shafir about integrated care in the EU. In the second webinar, we considered with examples how integrated care differs due to various particular system contexts and moderators, such as policies, strategies, and system characteristics, and how these can impact on the degree and outcomes of integrated care. In this third webinar of our 5-part series, we consider models of integration, the different classifications of the mechanisms through which integrated care is delivered, and how these might be impacted on by system moderators. Integrated care varies a lot. In our study for Shafir, our assessment of integrated care in all the 28 EU countries plus Norway and Iceland highlighted about 550 integrated care initiatives put in place to improve the quality of care delivery and reduce costs. These vary markedly in their characteristics, depth and breadth of integration, and their geographic sizes and population groups covered, and what condition they might focus on. Integrated units can be different organizations that provide specific aspects of care to the same patients while sharing back office functions, such that their patients are handed off seamlessly between them and cannot tell them apart. They can also be as simple as organizations sharing information systems that allow for patients to move about seamlessly. To help people navigate their way through the varieties of integrated care initiatives that exist, researchers have described them in different but complementary ways. Shortell et al. In 1994, as well as Simeons and Scott in 1999, suggested that integration of care can be categorized into 4 types. The first is functional integration, which describes a scenario where key back support and non-clinical support functions and activities are integrated, such as financial management, strategic planning, and human resource management. In this scenario, the integrating units retain their individual identities, but utilize a streamlining of back office functions to reduce costs. Organizational integration is when organizations are brought together by formal mechanisms such as creation of networks or contracts, with each remaining separate but playing a specified role as agreed by the partners. Professional integration is where different services are integrated through strategic alliances of health and care professionals within and between institutions and organizations. Clinical integration is found where care is provided by professionals to patients in a coherent clinical process or set of processes within and across professions, such as when care is coordinated for individuals. Care integration can be classified according to the system levels it involves. Care providers can be categorized as being at the primary, secondary, or tertiary care level. Care can either be provided by organizations that are horizontally integrated, in which case services that are on the same level of care delivery, such as primary care providers, may be integrated together. Care could also be vertically integrated by bringing together organizations at different levels of a hierarchical structure under one management umbrella, such as when primary and secondary care providers are integrated. Lloyds in 1999 described 3 levels of connection between elements of a care system across the integration continuum. He described linkages, which is when organizations retain their own service responsibilities, funding, and eligibility criteria across and operate through separate structures of existing health and social service systems, but are loosely connected to deliver services. Coordination. This is when additional explicit structures and processes are implemented to coordinate care across various sectors, such as the routine sharing of information, discharge planning, and case management. Full integration describes a scenario in which one integrated organization or system assumes responsibility for all services, resources, and funding, which may be subsumed under one managed structure or through contractual agreements between different organizations. We should now consider some examples of how some of these approaches operate in practice. In Spain, Pine stands out in the Basque region due to the special population it targets. Pine implements a fully integrated model of care for children with special healthcare needs. It is integrated vertically and horizontally with systems that allow for functional and professional integration, but still allows for component parts to be organizationally and clinically separate. It uses multidisciplinary groups comprised of professionals from the healthcare, social services, and education sectors to create appropriate structures for care coordination and tools to enhance early detection of situations of risk. The moderators of integrated care in this region are driven by a regional approach to care, supported by the ethos of a political leadership that has allowed for the legal environment and financial systems to be developed to support this multi-sectoral approach to care delivery. The state of Oregon in the United States established a network of 16 coordinated care organizations in order to drive improvements in care quality and reduce costs. Based on the use of patient-centered medical homes, these organizations act as coordinating centers between diverse groups of independent providers of government-funded care. This coordinated approach to integration is supported by the fact that Oregon spends its Medicaid funding mainly through these organizations. This moderating factor compels providers to integrate organizationally, with the CCOs acting as central coordinators, ensuring that the patient remains at the center of care. In Saudi Arabia, health system reforms are being brought about as part of Vision 2030. This includes the design of clusters of providers using accountable care models that will result in vertically and fully integrated cluster-based care organizations responsible for the population health management of at least 1 million people each. Ongoing reforms are building the moderating elements, including financial, regulatory, and organizational elements that will allow for the integrated delivery of care. Irrespective of how you might classify and subdivide different models of integrated care, one must keep in mind the fact that integrated care models feature a much higher degree of complexity and variability than one might imagine and cannot always be easily categorized. As always, the moderating factors in a locality play a huge role in the characteristics of the integrated care model employed. In our next episode, we discuss how to make change happen by integrating care for patients. Till then, bye-bye.